How many of you have heard about people who have got spinal cord tumors and have suffered to spasticity? Hi, I am Siddharth. I am working as an advanced neuro rehab specialist at PRS Neurosciences and I am trained as an occupational therapist. Unlike spinal cord injuries, these tumors are fundamentally abnormal growth of cells. Okay, now any cell which is alive can develop a tumor. Okay, if you look at the spinal cord, you have the spinal cord itself, you have the covering of the spinal cord, you have the places from where the roots they come out. All these cells are prone to developing different kind of tumors and can cause variable different kind of concerns. Okay, now for this tumor, either it can grow outside the cord and compress the cord, or it can grow within the cord and compress the cord outward. Both are possible. So if you call it as a extradural tumor or intradural, the covering within the dura but extramedullary outside the spinal cord, or intradural intramedullary, and all three of them they can give a different presentation over the time. Okay, now we understand that there are different cells which have abnormal growth, which I have been telling. Each one of them, they grow at a different rate. Each tumor grows at a different rate, and that is something which is for it's a hardcore oncology kind of a subject. But as a neuro rehab specialist, knowing what kind of cell is that and what is the expected rate of growth of the tumor, is it benign, like is it going to stay in one place, are there chances that it becomes malignant, that it starts spreading across the column, gives it makes a difference for us to understand will a person go and land up having spasticity related concerns or not. Okay, now as we know that there are two descending tracts, two pathways, or consider two wires, just to imagine, which are coming from the brain going down in the spinal cord and controlling different aspects of your voluntary movements. Some are controlling only the axial body, some are controlling the limb movements also. Each one of them can get compressed and cause an issue, right? In this case, because it is more compression related, we are anticipating two kind of problems happening. One is increase in the local reflex activity. Second is reduction in the blood supply.
When you say local, where?
So what happens is, because these tumors, they are growing at a specific location along the column. Like think about a column in your house, a pillar can be broken at different levels. So the spinal cord also can have growth at different levels, right? Each one of them, they will produce a different set of motor symptom. For example, if it is high in the neck, you may anticipate some pain around the shoulder, right? You may anticipate some pain radiating up to the neck. You may feel that the shoulders are weaker but the hand is perfectly fine. You may feel that there is some tingling sensation going down to the hand, right? Now like any other condition, like a spinal cord injury, tumor can also present with spasticity. Okay, it's not new. Like in spinal cord injury, you have a shock phase and then you land up having spasticity after that. In tumor, either you can have slowly progressing kind of a spasticity, or after the surgical management, you may have an initial shock phase and then you have spasticity. Okay, so the reason may be different, but their mode of recovery are more or less similar. Okay, now a person who has undergone the major difference between a person who has a trauma and a person who has a neoplasm or a tumor sitting in the spine is the other medications which are going along with this particular management for spinal cord. Because the medications for tumor, they weaken the immune system, they tend to fatigue the person, right? And as it is, when the spinal cord is getting involved, the muscles are getting weaker. Okay, so in that case, it's like double the effort for the therapist and the patient. Is a double the effort to come out of that. So that's where a lot of psychosocial approaches are used to give them that psychological support that you can go through this. So a lot of mental support is given, because one, it is painful, you are nauseatic. On the other side, you are feeling spasms and spasticity happening. The tumors which are in the exiting nerve roots, meaning we call it as a cauda equina, which is towards the end of the spinal cord. When the tumorous cells, they start developing there, they may not cause spasticity actually. Okay, they cause more of radicular pain, which is a topic for another different kind of video. But that is one sign which we, like, if someone is having frequent pain and gone through multiple managements, this is something which a neurologist will for sure like to investigate and make sure that it is not ascending up, the tumor is not spreading upwards. Because if it's spreading upwards, then you start worrying about the onset of spasticity in that case. In spinal tumors, the reason for spasticity comes primarily from the compression of the pathways, which leads to disconnection of the information coming from the brain going down to the spine, which needs to reach the muscles, which does not reach in this case of a tumor. Now, depending upon from where the tumor comes in and how much compression is there, and at what level the tumor has happened, the frequency of spasticity differs. Most commonly seen in the cervical spine and in the thoracic spine. If the tumors are developed there, we frequently see spasticity coming up. If it is lower in the lower areas, the incidence of spasticity is comparatively lesser, but yes, we do see people who get spasticity. Now, based on the severity of the spasticity and the combination of spasm and spasticity, we look at the management, how we want to do. Do we want to go for initial conservative management? Maybe simply start with positioning the limb, elongating the limbs time to time, and making sure the limbs are moved frequently. Versus we want to add some pharmacological management, like adding medications which helps in modulating the amount of impulse which is going from the brain down. Or do we want to reduce the effect of the impulse coming down on the muscle, so that the muscles relax better, so that the caregiver burden comes down, or the retraining of the patient gets better and they regain the functionality. If it is really bad, in some cases we do go for local antispastic measures like Botox, and in some cases we look if ITB is possibility or not. Eventually we see that because the functionality starts getting better during the rehab process, we determine to where can the spasticity be modulated so that functionality is not lost. That means you're looking at the good part of the spasticity which comes back, and how much we want to reduce the spasticity. That means the bad part of the spasticity which is actually affecting the progress, we want to modulate that. And eventually the attempt at PRS Neurosciences is to achieve the best functional capability with least amount of compensation, so the person goes back to the community.